So the dream outcome for any translational research study is to have something impactful to patients. So systemic lupus erythematosus, or SLE as we call it, and in most cases just lupus, it's simplified down to, is an autoimmune disease, a chronic inflammatory autoimmune disease. And what that means is that it's all around your body. So patients with lupus, they have an immune response that normally would be a good thing, but it actually starts to attack your own body tissue.
Lupus, formerly known as systemic lupus erythematosus, is a chronic autoimmune disease in which the body's immune system mistakenly attacks its own healthy tissues and organs. Normally, our immune system protects our bodies from infection. In lupus, however, our body's immune system becomes overactive, producing antibodies that attack normal cells, leading to inflammation.
What happens to patients is that depending on where that inflammation takes place, so it could be in your kidneys, in your lungs, in your heart, in your brain, so it affects various different organs depending on where that inflammation deposits. And that's important because it's a very heterogeneous disease, which means that it's different in every patient. And this is because of this chronic inflammatory nature, so it can really affect a different organ in one patient compared to another. And this damage can in some cases be irreversible.
Due to the nature of lupus affecting multiple systems, symptoms can vary. From mild to potentially life-threatening, the disease shows up differently in each person.
So the gap in the research and knowledge around lupus in particular is trying to identify why the disease is so different in different patients, and that makes therapies really hard to develop. And that's why there's been a huge lack of therapies developed for lupus over the last 10, 20 years.
In the UK, lupus affects 1 in 1,000 people and around 90% of them are women. Approximately 15 to 20% of cases are diagnosed in childhood. Lupus that shows up in childhood, however, tells a much more severe story.
Patients can develop the disease before the age of 18, and for some reason, and we're exploring these ideas, the patients develop the disease in a more aggressive way. So they get more organ damage and tend to have worse longitudinal outcomes.
Children living with childhood lupus are 6 times more likely to die than adults living with the same disease and face a higher risk of irreversible organ damage. With no cure yet for lupus, research into optimizing current therapies and identifying new therapeutic approaches is essential.
Specifically, I'm working on younger patients with juvenile-onset lupus, funded by this Royal Free Charity grant, is to look at a protein called interferon. And this is specifically interferon alpha, which is a type 1 interferon that is heavily involved in driving lupus.
Interferons are a family of proteins that the immune system releases to defend against viruses. They act as alarm signals to other immune cells that a virus is present. In patients living with lupus, the interferon pathway is chronically switched on, even when there's no infection. This overactivation drives inflammation throughout the body.
A lot of therapies are either approved at the moment, but also in development to try and target this interferon pathway. So by reducing the amount of interferon, you can prevent the inflammation from happening. But specifically what this grant's been looking at is trying to find biomarkers to identify patients that either do or don't have a lot of this interferon in their blood. And what that will do is tailor these therapies specifically to patients that have a lot of interferon and help their disease.
George's research looks at whether we can identify biomarkers, tiny clues in the blood, which are associated with increased levels of interferons so that we can create personalised treatments to reduce the impacts of symptoms for patients. While interferon-reducing medications exist, treatments follow a one-size-fits-all approach that doesn't optimise treatment for patients.
Due to the increase in research and technologies that allow us to look at the immune system, those therapies have switched to things we call biologics, and they target more specifically different immune cells and things that immune cells produce. So that's improved the specificity of the treatment that we can give. But what's lacking is the personalised approach, so making those treatments specific for certain individuals. So that's where the field's moving, is using these technologies to try and stratify patients for using these therapies.
George's research aims to identify ways to personalise treatment for people with lupus, tailoring therapies to each patient's unique biology. This approach could help reduce side effects, improve symptom control, and lower the risk of long-term organ damage. With no cure yet for lupus, research like George's brings us closer to transforming care. turning scientific discovery into real hope for these patients.
My core funding is from versus arthritis. I'm on a fellowship that's given me independence in 2022, so I've been able to explore my own research ideas and build a platform to investigate these younger patients. But what this Royal Free Charity grant's done is allowed me to bolster that research and identify specific markers of this interferon pathway to stratify patients and really get that translated into a clinical setting where you can identify which patients will benefit more from anti-interferon therapy. So it's a really translational project that can get back to patients, which I think is really important. Something else that the grant's done for me is provided me with funding to travel. So I've been able to present the research funded by this grant at the largest European rheumatology conference. And that was in June, and that was a really exciting opportunity to present the work that's been funded by this grant. And finally, for the importance of this research, as I say, it's that translational aspect and getting something that could make its way back to a clinical setting to identify patients for stratified therapy.